against the PCI, and I requesting Dr. Kunal Sarkar, and he is the chairman and head of the department cardiothoracic surgery, medical superspecialty hospital. So, Dr. Kunal, please talk against the doctor surgery in favor of that for revascularization. There is no doubt the proximal LAD with a significant disease, the revascular must be done. So, it is whether it is PCI, whether it is surgery, that to be decision to be taken today. Dr. Sarkar, please.
Thank you, Dr. Panja, and thank you to Shantanuda for the opportunity. Right. Now, you see, we are in a kind of situation where we want to have an assessment of what's happening around us with a slight view of the long term. We are not like the Mayans who think that every 2 years the world is ending. So let us look at the assessment of our specialty and disease domain rather than this periodic sort of 3-monthly interspecialty dogfights, which has characterized our two mutual specialties, perhaps ever since the first angioplasty was done. Now, Dr. Hajra, he impressed me tremendously with two things. One is his speed. Secondly is he has a look in his eye which tells me that he knows most of what I'm going to say, and he's basically living in a state of denial. There are two very important things I picked up from his hurricane lecture. One was his line when he said that he may be heading the wrong way. And secondly is 6 times his reference to ladies, both in pictures and in case reports. So it tells me in life it is never too late to start. Now, the proximal LAD was otherwise referred as a widow maker. And we know all the reasons, why you ended up the problems with LAD. So I need not be, preaching to the choir on that respect. Now, it is absolutely true. Let us take a step aside of this, backbiting and back scratching. That yes, the gap between the data, the stent patency, etc., in the LAD area has narrowed tremendously. Over the years, the acute problems have improved. But long-term issues like MI, repeat revascularization, increase of MACE, and compromised survival, that is what should bother. That is one bit of a data that should bother the people who are at the treatment end of it. This kind of thing has persisted both in the cardiological and in the cardiac surgical literature. Now, we go back to the seminal graphs from Hanan, which was based on the New York Registry of 2008, which showed distinctly that whether the LAD was treated in isolation or the LAD was a part of a multi-vessel disease, somehow a surgical or a left internal mammary-based approach to the LAD gave better outcomes in sort of 3 years plus analysis. And there is no point us regurgitating that data, which is of 2005, 2008, and things like this. But what is a little bit more contemporary is if you look, yes, admittedly, surgery does involve scars, surgery does involve anesthesia, surgery does involve a bit of post-operative pain. But in this very elegant meta-analysis done by Umberto Benedetto from the University of Oxford. So if you take, overall view of more than this meta-analysis and more than 20,000 patients, it spread out over sort of 8 major randomized controlled trials. So at the end of the day, what you see is a 154% increase in repeat revascularization, a more than 50% increase in mortality, twice as much increase in MI. And yes, of course, we surgeons have to be very, very aware of the fact that on our debit side, we have an incremental risk of strokes of around 25 to 29%. Yes, that problem is there with surgeons. And if you come down to the data, regarding proximal LAD in itself, there is an Italian publication by Rafael Cavalcante, and he deals with more than 1,000 patients which had proximal LAD lesion again, and again the same data shows up. I mean, that's a kind of nostalgic regurgitation is unnecessary. And if there is one data set which can give us a feel of the ground as regarding the problems of a surgical revascularization and angioplasty in proximal LAD, it is the data that we had with mid-cap surgery, with minimally invasive revascularization for isolated LAD lesion that our chairperson referred to. And even in this data, you see, if you look at things like MACE revascularization, etc., there was a trend towards sort of increased hazard-free procedures from bypass. But there is a twist to the tale, which I think Dr. Hajra has missed. And the twist in the tale that he has missed is it comes from certain analysis, and this was a publication that happened in 2012, I think. Kapoor from Stanford, he said that yes, without a doubt, there was an incremental rate of repeat revascularization in proximal LAD intervention, but survivals were same. Now, I will tell you the statistical jugglery where this happened. And this was reflecting all this interventional triumphalism with proximal LAD came at a juncture of 2014 guidelines for myocardial revascularization. Till the 2010 guidelines, the ESC guidelines on myocardial revascularization, you have a proximal LAD being given a preferential 1A indication for surgery. But this is the 2018 which is flashing in front of your eyes, but it did not happen in 2018, it happened in 2014. In 2014 guidelines, some kind of the parity was restored. 1A was given for both. The question is why? If you read through the text of the guidelines, 1A was given based on survival. And survival was calculated not on the index treatment, but survival was calculated on an intention to treat basis. So whenever you have guidelines which are based on RCTs, and RCTs determine survival by the intention to treat basis, so all the people who would have had repeat revascularization following proximal LAD or whatever lesions were sort of returned back to their original basket when the survival was calculated. And this really opens up a question. I'm sort of trying to get out of the domain of this, me, you, me kind of situation. But if you understand the embedded interpretation as to what was the guiding figure that enabled this shift of stance in 2014, this is exactly what happened. It did not happen on MI. It did not happen on revascularization. It only happened on one criteria, which is equivalent survival, which was based on the intention to treat basis. So this is a fundamental axiom of evidence-based medicine that we have to appreciate. And, I don't want to run through the same storm that Prakash ran through. I agree with much of he has said. But look, there are certain weaknesses. There are certain weaknesses in the modes of intervention that we are using for treatment of coronary artery disease. PCI definitely improves angina. This is a report from Oxford. This was submitted to the NICE, the NHS decision-making organization. It does not extend life. The PCI does not improve survival. It does not improve myocardial infarction to some extent. And what is more obvious is the belligerence with which Dr. Hajra made his presentation, that he discounted that another treatment would be possible that gave us improved hazard-free procedure, improved survival, and he was a baker who had a biscuit with only one side to it. So this is where I think we are being unfair to the options available to us. And let us, once again, Get out of this short-term sort of, penny pinching between two specialities, because we are standing, as scientists, we are standing at a very epical point where the quality of data in coronary domain is under serious question. Today, if we are an ostrich, if we do not recognize the data crisis, which is there in the domain of coronary work, we will be fooling ourselves. I need not recall to a very learned audience the problem that happened, the Panama Papers of evidence that happened in your Excel trial. And similarly, if you look at all the long-term recommendations, whether it was from the Lancet, whether it was based on the New England, the Jack, which viewed overall, and it said that if we still compare apples to apples and look at total mortality, total survival, yes, there was an inherent weakness. I am not claiming that bypass is the ultimate sort of panacea for all problems. But what I am claiming is percutaneous intervention, which is a significant development in the field of therapeutic medicine, does have a few creases to sort out, does have a few important weaknesses to consider, and the sooner we do it, the better. And those of you who are in this sort of in the library, in the supermarket of stent business, every time a new stent comes out, you are trying to rediscover the wheel under the pretext that a chocolate flavor stent has been replaced by a strawberry flavor stent. You are back to the short-term syndrome, that 1 year, 2 year data, and all kind of long-term perspective is brushed under the carpet, under the presumption that, look, we have to sacrifice the long term for the short term, because yet another color, favor, absorbable business has landed in the market. Now, this is not scientific introspection. There is something very important for which coronary artery data will be heavily criticized in the near future, both surgery and intervention. And that is called a new yardstick, which is called a measurement of data fragility. And data fragility refers to the fact that the kind of evidence trials that we are producing today, are they actually standing on a good enough margin? If I take a few patients from either side, does it radically change the outcome as to what is about to happen? So there is something in the domain which we can talk about at some later meeting in the future, which is called a fragility index of data, which is coming out. And 60%, more than 60% of the data based on which our guidelines get framed, does fall in this very dangerous zone of being very fragile data, which, if you have a bit of a wind blowing the wrong way, the entire interpretation of your data and trial will change. And how many times have we highlighted that we have the pitfalls of running into the territory of dressed up bias in the form of these flood of industry sponsored trials, right? I believe, that even your partner 3 is not heading the right way at this point of time. So please, we are investigative scientists. We are interventional therapeutic people. We are not here of peddling implants. So let us take a proper view of what is happening. And this sort of, constant kind of bickering based on very thin, wafer thin short-term data is extremely dangerous. Yes, as coronary surgeons, as cardiac surgeons, we stand accused that apart from off-pump surgery, arterial conduits, surgery is not a discipline where something new happens, where some new stent, where yet another compound, yet another mesh size, yet another different scaffold comes out, 4 times a year. It does not happen, because surgery is an intellectual property right, belongs to the surgeon. They think it out. They do the philosophical thinking behind the procedure. We are not end users alone. we are thinkers who use our own thinking. Therein lies the difference. And what is needed today is if we've had enough, we as both cardiologists and surgeons should be reasonably tired of these kind of, short-term fistfights. I think, after half a century of this therapy having been practiced, we have to look at new horizons. We are trying. We have just got the ICMR funding for India's first five-year predict trial, which will compare grafting strategies in diabetics. And I implore to all the senior people, so many of them I can see on the screen today, that the sooner we evolve, not through this kind of debates and pinching at one another, we need to come up with an Indian advisory of management of coronary artery disease. We cannot have Indian guidelines. The reason we cannot have Indian guidelines is because we do not have enough Indian evidence. If you don't have your own evidence, you cannot have guidelines which emanate from that evidence. Because if we don't do it, I can see it in the horizon that well within a year, we will be operating on the Niti Aayog ICMR laid down guidelines, which will not, in this current political environment, which will not leave us with a lot of latitude for debates. So, friends, please let us abandon this habit of this short-term dilemma and delirium. Let us get out of this habit of putting band-aids on stab wounds. Every coronary lesion, as Prakash said, had to be treated, evaluated on its merit, whether be it PCI, whether be it CABG. CABG has to introspect and look at the kind of areas in which it is getting stuck, and PCI, formed in abundance, has to emerge from this addiction to short-term data. Thank you very much. I remain.
Thank you, Dr. Sarkar. Excellent presentation. Now, call I Dr. Hajra to answer his question to support yourself.
Look, this is not a debate. We won't go in that format.
Okay.
This is a knowledge sharing thing. So Prakash has said his part. Kunal has said his part of the story. We have three very intelligent chairpersons. Let us hear from them. Plavon is here.
Plavon?
Yeah, thank you so much. I mean, it had been wonderful listening to the two very eloquent speeches. And Dr. Hajra really surprises me always with his level of confidence. I think it's better to, just sit back a little and think, are we really doing the right thing? It's good to be a bit doubtful than to be so sure. Just 2 points I'd like to make. When you're discussing about two modes of treatment for a designated lesion, and the jury is still out on that, I think we need to remember 2 points. The patient can very easily be misled about the validity of unproved claims. I hope you understand what this means. They can be misled about the validity of unproved claims. And secondly, I think every patient should have all the data. He should not be stripped of relevant information regarding the alternative treatment modality so that he can come to a proper decision. So by this I mean, give them all the data. In fact, I think it was in Jack, things came out that not so fast. The cardiologists were told not so fast, just take it easy. Putting in stents everywhere, proximal LAD is an area which needs to be, we know that a lot of myocardium is in jeopardy, and I think that needs to be handled.
Right.
You have another co-chairperson, Shuni Banerjee. He has come. I have seen.
So Banerjee, any comment now?
No, this is a debate. I think.
No, this is not a debate. You give your point. You give your point.
My point is, if you have a proximal LAD lesion without other arteries being involved, we need to do a fractional flow reserve when we are in doubt. The NGO, what Dr. Prakash has showed, it's very clear that it is a very significant stenosis. But if there is a doubt, we need to do a FFR and do it. The other thing is, I think there are few important points from Kunalda. Is every new year a new stent is coming and we are thinking this may be better. So actually we are also confused with so much stent. But the good thing is that the new generation stent with new antiplatelet and use of more imaging, not in the simple cases, actually the long-term result is equivalent. So we need to look into the cost benefit ratio. If a procedure can be done in a day and the patient can go home, that should be acceptable modality of treatment. But obviously, I should not miss this patient with proximal LAD lesion symptomatic because of severe anemia or coexisting mitral or triaortic valve disease, where I must share my knowledge with physician or surgeons where they will be able to give a better job. I think this much.
Okay, my final conclusion is that if it is patient with the proximal LAD combined with associated multiple vessel disease, so in that case, if it is with diabetes, so that case surgery is no controversial. 10 years mortality difference is very low in cases of the surgery. And second thing, if we do the angioplasty, in that case, restenosis, revascularization rate required is very high. So, but if the patient without diabetes, even 10 years follow-up and PCI versus CVG, there is no difference in considered to all causes of mortality and MACE. Of course, the restenosis rate higher in cases of revascular or the PCI. I admit that Dr. Sarkar rightly pointed out minimal invasive technique. In that case, if it is only isolated proximal, it's very good. Similarly, simultaneously, as the interventional cardiologist also support the critical stenosis and the significant symptoms. Nowadays, very good stent that is within the ultra thin stent available is the result is nearly the same. But there is no result isolated LAD which is better, whether it is PCI, whether it is surgery is not concluded. But if it is young patient, nobody wants the surgery. If it is isolated proximal LAD, always angioplasty, always PCI. Not a young patient, nobody wants for the surgery. This is very important issue. You should remember that the Grungic is first case of angioplasty by plain balloon done in the proximal LAD. And this patient survived up to 22 years. Of course, after follow-up, another lesion developed on the LAD, proximal to the LAD. So therefore, even proximal LAD, even plain balloon, will live about 22 years without any surgery.
So, thank you very much, Monotuzda.